السلام عليكم ورحمة الله وبركاته. I am Professor Dr. Mohamed Hamdy. I am Professor of Clinical Hematology at Ain Shams University, Cairo, Egypt. This is the second lecture for discussing the physiology and the diagnostic investigations for undergraduate who are going to study a course in clinical hematology. In the first lecture, we discussed the physiology of the blood and its composition. And now we will discuss the investigations that will be needed during the course. Objective of these two lectures are understanding blood composition, plasma, packed cervulae and buffy coat, to interpret RBC's indices, platelet function, and white blood cells differentials. We have discussed number 1 and number 2 in the previous lecture. Today's lecture, we will discuss the diagnostic tools for the investigations and the investigations for the diagnosis of different cases of hematology, and we may give some clinical scenarios, especially in bleeding. In the previous lecture, we discussed the composition of blood. For a 100 milliliter of blood, 55 milliliter will be of plasma that contains 90% water and 7% proteins, about 45% of RBCs, and this means 45 milliliters of RBCs, and it is called packed cervulae or hematocrit, and just less than 1% of semi-transparent part, which is called buffy coat, which contains the white blood cells and platelets. The plasma contains, as we have discussed, proteins, iron, water, nutrients, waste and gases, and the most important are the proteins that we can encounter with a lot of diseases of hematology. The buffy coat contains mainly the white blood cells and the platelets, while the packed cervulae or hematocrit contains the red blood cells. The blood volume is about 4 to 5 liters in females and 5 to 6 liters in males, and the composition is 55% plasma and the formed elements about 45%, as we have mentioned in the last lecture. Today's lecture, we will discuss blood investigations starting from this slide. This is a list of the investigations that we will discuss in this lecture. There are about 17 different kinds of investigations that we will encounter within the course. Some of them you are familiar with, and some of them we will discuss again in the assigned lecture and assigned disease that will have we use this investigation in this disease. The first and the most important test in hematology, and I call it the stethoscope of the hematologist, is the complete blood count. You can find this into different other abbreviations. So do not bother to see it in different abbreviations and different sentence. The sentence that is used in this course will be the complete blood count. Complete blood count, from its name, means that we count everything in the blood that can be counted, and we are aiming to the cells only. We are not counting proteins because proteins are weighted, not counted. So the things that can be counted in the blood are the cells. This is the shape of the report that comes from the machine. The machine, as you can see, it is called the Coulter machine or flow cytometric machine. It takes a sample from a tiny needle, and it takes a sample and do a lot of tests inside it. No need to understand the mechanisms of the test done in the Coulter machine, and it gives us a report in this white paper on the left side. Small white paper. The full report looks like this on the right side. There are some elements and some measures. We have discussed these measures in the previous lecture, and we have some graphs. We will concentrate on this picture because it will show the RBCs count, the hemoglobin, the indices, the platelet count, and etc. So the complete blood count, the first investigation, it is a basic screening test that evaluates overall health and it detects disorders like anemia, infections, and leukemia, thrombocytopenia, thrombocytosis, any derangement, any going away from the normal pattern, you can diagnose. So my advice when you see a complete blood count or a CBC, do not look only to the hemoglobin level. Look to the hemoglobin level, look to the indices, as well as look to white blood cell count and its differential, and do not forget to look for the platelet count. It is very important to recall back what is meant by mean corpuscular volume, what is the normal range, and what does it mean when it is microcytic and macrocytic. You must understand what are the normal differential count and the normal count of white blood cell and the normal platelet count. This is for the undergraduate level. The second most important thing is not depend only on the machine, but you must look to the film that shows this kind of blood cells. Because sometimes the count is normal, but there is some abnormal forms inside the blood. And seeing this abnormal form may give you a hint about the disease that underlying the condition. For example, if you see a patient coming with hereditary anemia and his hemoglobin level is low, and the patient comes into attacks of hand aches and chest tightness, and then you make a blood film and see the cell number 2 from the right or number 4 from the left. These cells look like a sickle, so the diagnosis at that time will be sickle cell anemia. So seeing the changes inside the blood film will give you a lot of hints. There are many abnormal forms of RBCs that can be found. One of them very small blood RBCs, or very large one, target cells, the most right one in the upper panel, which contains, instead of central paleness, there will be a central opacity, like a target paper. Schistocytes means fragmented RBCs. It has another name like helmet cells. Teardrop cells occurs in myelofibrosis, and spherocytes occurs in hereditary spherocytosis. The investigation number 3 is called reticulocytic count. Reticulocytes means a cell that contains reticulum. This reticulum consists of remnant of ribosomal proteins. This reticulocyte is the last cell before mature erythrocytes, so it is a little bit immature from the mature erythrocyte. This reticulocyte, if present in a large amount or in high concentration in the peripheral blood, this means marked destruction of the blood cells, so that the bone marrow is secreting more and more little bit immature reticulocyte to compensate for the anemia that occurred due to the hemolysis. There are many measures or indices to measure the reticulocytic count. One of them is called absolute reticulocytic count. The second one is called reticulocyte percentage. And the third one, the most important one, is a corrected reticulocytic count. At any time, if there is decrease of these counts or percentage, this means aplasia, that the bone marrow does not produce enough amount of RBCs, while showing this amount or this concentration or this corrected concentration in the peripheral blood means that there is a lot of destruction and early forms are appearing. This means the cases of hemolysis. The left lowermost picture of staining of reticulocytic count that appears and targeted by the red arrows is the staining of this reticulocytic count by the methylene blue stain. So it shows as the reticulum or shows as the ribosomal proteins RNA that is present inside the reticulocytes. Number 4 is the ESR or erythrocyte sedimentation rate. If you leave anticoagulated blood into an erect position like this, like in this graph or this picture, the cells tends to adhere to each other and go down and sediment. But because these cells, RBC cells mostly, are coated by charges, they repel from each other. This prevents them from sitting to each other, and they prevent them from going down rapidly. So within 1 hour, the maximum for the normal person is 15 to 20 millimeters. But for any cause that causes marked inflammation that secretes protein, these proteins will enclose or envelop the RBCs, and this will prevent the negative charges. And hence the RBCs will adhere to each other very rapidly, and the sedimentation becomes extremely rapid. So in such a condition like severe inflammation, like cancers, these cells will sediment very rapidly, and hence the ESR becomes very high. So instead of 15 to 20 millimeter mercury for a first hour, it will make maybe sometimes 70 or 80, and sometimes more than 100 within the first hour. So if you find an ESR very high, like 70, like 80, this means inflammation. Now we will discuss some investigations that occurs in a special kind of diseases, special kind of condition of hematology. We will start by investigations of cases of anemia. For the iron study are some measures like serum iron, which is the absolute level of the iron in the blood, and the ferritin, which is the most important transferring proteins for the iron, and it is a very important measure. And the two other measures like total iron binding capacity and the transferrin saturation, and both of them shows how much available places on the transferring protein that transfer iron is available places for iron to load, or what are the absolute load of the iron over this transferrin saturation. We simplified it like and give an example like a bus. So if this bus is full of passengers, so it will be the transferrin saturation, amount of iron already over the transferrin. While the total iron binding capacity are the empty places on the transferrin, how much it can upload or can take more passengers. The serum iron range from 60 to 170, the ferritin range from 30 to 300. The definition of anemia when the serum iron less than 40 or the ferritin less than 15, and the transferrin and total transferrin saturation and total iron binding capacity are different from each other. That total iron binding capacity is high in iron deficiency anemia. This means that there is no places, while transferrin saturation is low in iron deficiency anemia. So these two are examples of reverse or measuring the same thing in different perspectives. The most important measure here is the ferritin. Next is the vitamin B12 and folate deficiency. The vitamin B12 range from 200 to about 1000 picograms per milliliter, folic acid between 2.7 to 17, and if they are very low, this means a megaloblastic anemia, and folic acid deficiency less than 2 is important also in pregnancy and in megaloblastic anemia. Then hemolytic anemia analysis investigations. Some hemolysis means destruction of the RBC. This will lead to increase in lactate dehydrogenase, increase in indirect bilirubin, and as a result of destruction, the bone marrow will release more reticulocytes. This will lead to increased reticulocytic count. And if it is decreased, the investigation of decrease, there is decrease in hemoglobin and decrease in haptoglobin. And in the urine, we will find increase in urobilinogen and increase in hemosiderin. Investigation number 8 is the hemoglobin electrophoresis. From its name, electrophoresis means separation of hemoglobin protein by using electrical current. This will separate hemoglobin into different positions according to the weight and the shape of this hemoglobin. We can recall the types of hemoglobin from the physiology that we have discussed before, that the hemoglobin is of normal adult is composed mainly of what is called hemoglobin A, more than 95%. and very small amount of what is called hemoglobin A2. In some cases of chronic anemia, chronic hemolytic anemia, hereditary one like thalassemia, there will be increase in secretions of normal or abnormal hemoglobin, and this will lead to decrease in hemoglobin A and increase in hemoglobin A2, for example, hemoglobin F, or if there is abnormal form of hemoglobin will be sensitized. The patient who is suffering from sickle cell disease, you will find there will be increase in hemoglobin S and a decrease in hemoglobin A. So when we seeing an hemoglobin electrophoresis panel, you must look for the concentration of hemoglobin A, the concentration of hemoglobin A2, the concentration of hemoglobin F, and if there is any other abnormal hemoglobin like hemoglobin S. The next test is called Coombs test, and the Coombs test is for immune hemolytic anemia. In immune hemolytic anemia, there is antibody simplified here by the Y-shaped structure. When this antibody is present in the peripheral blood, it will attack the RBCs, leading to destruction of these RBCs and hemolysis. So how to know if this antibody is coating the RBCs? Just by putting antibody that will make the RBCs adhere to each other, and hence there will be clot formation. This test is called Coombs test, and nowadays it is called direct antiglobin test, because we are using antibody against the antibody. Sometimes the antibody is not present over the RBCs. They are just present in the plasma. So at first we will put a sensitized or not normal RBCs that can adhere to these antibodies, and then repeat the Coombs test as before. And at that time the test is called indirect Coombs test or indirect antiglobin test. The difference between the direct and the indirect is a kind of antibody. The antibody in the direct Coombs test is very strong antibody that is directly adhere to the RBCs, while the antibody in the indirect antiglobin test, it is just in the plasma. So it is not very strong antibody and needs another carrier to carry the antibody over it. We will discuss this in details in autoimmune hemolytic anemia. So for hemolytic anemia, we have discussed some tests, some like chemistry, like LDH and bilirubin and urobilinogen and hemoglobin in urine, some like hemoglobin electrophoresis like in cases of thalassemia, and Coombs test like in cases of autoimmune hemolytic anemia. But there are a lot of varieties of cases of anemia, especially hemolytic type. Some of them need a special kind of tests, like osmotic fragility test in hereditary spherocytosis, like cycling test, like flow cytometry, like cold agglutination, like assay of a protein called the Adams 13, and a blood culture. We will not bother now by these kind of investigations, but to know that the hemolysis investigation needs a lot of different tests, not only the three tests that have been discussed before. The test is called blood grouping typing. We can recall from our previous study in the primary and secondary schools that we have different blood groups. These blood groups are depending on two important factors. The first factor, some proteins over the cells called the antigen, and some antibodies in the serum of the patient. Usually we have two kinds of protein. The first protein called protein A, second protein is called protein B, leading to group A and group B blood groups. If both proteins are present, the group will be called AB, and if neither is present, the group is called group O, or means group 0, there is no proteins. And there will be antibodies present in the serum of the normal person. This antibody is the antagonist of the amount or the name of the protein present of the RBCs. So if the RBC has group A protein, the antibody will be anti-B, antibody against the other group. And if the protein is group B, the antibody will be anti-A. And if both is present, there will be no antibody, because we cannot have antibody A or antibody B because both proteins are present. And if the patient doesn't have any antigen, he will have both antibodies, anti-A and anti-B. This will lead to some kind of matching process in which group A and group B must take either group A or either group B, and group AB can take from either group B or group A or group AB, and group O can never take from any patients with group A or group B or group AB, because both of them will have antigen and he has antibody and is against these antigens. And this will give rise to what is called universal donor and universal recipient. We will discuss this in the lecture of blood transfusion. The lower panel, the lower picture shows how we do the test. We can just put the blood and put the anti-serum. If we have anti-A, the antibody, there will be clotting. And when we have anti-B, there will no clot. So the blood group here will be group A, because the antibody against A, this will lead to positive. So the antibody here is positive. There's another system called RH system. We will take it in the blood transfusion lecture. But this is how it looks for doing the grouping test. Discuss investigation for hematological malignancy. Investigation for hematological malignancy is the bone marrow aspiration and the biopsy. Here we take a biopsy from the bone marrow to see the cellularity, if there is any dysplasia, if there is any fibrosis. And in this test, either the fluid of the bone marrow or the tissue of the bone marrow, this is known as bone marrow aspiration, and the biopsy is important for diagnosis of many important diseases like leukemia, myelodysplasia, aplastic anemia. The next test for hematological malignancy is called immunophenotyping, in which there are a lot of proteins present over the malignant cells. These proteins is called clusters of differentiation, or abbreviated as CDs. In this, we can diagnose different subclasses of leukemia and lymphoma by doing the specific CD marker over the cell. For example, in B-cell acute lymphoblastic leukemia, the markers will be CD10, CD19, and in cases of T-cell acute lymphoblastic leukemia, the marker will be CD3, and in cases of AML, the markers will be CD13 and CD33. Will be genetic testing. We have many kinds of genetic testing, and we use them in hematological malignancy mainly, but we can use genetic testing also in benign diseases in hematology and non-hematological diseases. The first test is a karyotyping, in which the chromosomes are marketed and stained. For example, we can diagnose what is called translocation 922 or what is called Philadelphia chromosome. This will be described in details in CML, chronic myeloid leukemia lecture. The other test is called FISH, as abbreviation of fluorescence in situ hybridization, and this is the rapid detection of specific mutations, like HER2 in breast cancer, or again, the translocation of the 922 will produce a chimeric gene called BCR-ABL. The last and the most important one present now in markets is called PCR, or polymerase chain reaction, and this can detect even 1 point mutation in one amino acid or one base pair, and this can be used in many applications now, either in medicine or in hematology. Fifth is the protein electrophoresis. Recall from the previous lecture that the most abundant protein in the blood is the albumin, followed by gamma globulins. So the normal here is that the albumin presents the most of the composition of proteins, as we can see it from the yellow graph. And the gamma globulins presents a little bit lower than that of the albumin. But in cases of multiple myeloma, when the plasma cell secretes many monoclonal gamma globulins, there will be increase in the graph, like we can see in the green part. This will lead to presence of what is called monoclonal gammopathy in cases of one of the malignancy of hematology called multiple myeloma. When we come to this multiple myeloma, we will discuss in details why the graph looks like this. But recall, there are two graphs, that one in the blue, this is the normal, and if there is monoclonal gammopathy, there will be another spike similar to that of the albumin at the gamma region. And there is a monomer, we can use our hands to present the normal graph of the protein electrophoresis, like we see using the fingers. Then we are talking about the investigation of bleeding. Lecture, we have said that we have 3 or 4 kinds of investigations for the bleeding. The first is BT, which measures the extrinsic pathway, the ABTT, which measures the intrinsic pathway, and there is a platelet count and a bleeding time. For the BT and the BTT, we need a blue colored cap bottle, while that of the CBC, to count for the platelet count, we need one of the purple color. For the bleeding time, this assists platelet function, and we are not using it now many times. We are usually using BT, BTT, and the platelet count. There are some advanced tests for bleeding, like factor assay of each of the 12 factors, von Willebrand factor assay, and antigen, D-dimer, and mixing studies. We will take this in details in the lectures of the bleeding. Sometimes we do what is called the platelet function tests in cases of platelet diseases. At that conditions, the platelet count is normal, but the platelet function is abnormal, like diseases like Lanzmann and Bernard-Soulier syndromes. We do tests called the platelet aggregation test. We will discuss in details at that time of platelet diseases. Example of how to interpret bleeding tests. For example, a disease called disseminated intravascular coagulation, in which there is widespread activation of coagulation system without bleeding here, and this patient will suffer from thrombosis, and the consequence, the bleeding will occur. At that test, the BT and BTT will become prolonged both. The platelet count will be low, fibrinogen will be low, and the D-dimer will be high. The second example, in hemophilia A, the BTT will be prolonged while the BT is normal. Recall again, hemophilia A is due to factor VIII deficiency, factor VIII present in the intrinsic system. So only BTT will be prolonged and the BT will be normal. The same also for the hemophilia B, in which it is due to factor IX deficiency. Also BTT will be prolonged while BT will be normal. The last example, in a disease called von Willebrand disease, we measure von Willebrand in type 1 and in type 3, in which there is partial, quantitative, and complete deficiency of von Willebrand level, while in type 2 there will be qualitative effect, in which the function of von Willebrand function is low, while the mass of the von Willebrand will be normal. So as a summary and the clinical integration, there will be some workup for anemia, to do the indices, to do iron study, bone marrow, and there is flow chart like blood film, like electrophoresis, like genetic test. This is flow chart of how we go through investigations. We can use different investigations at different levels to investigate for different diseases. While we are studying the conditions and the diseases chapters of the course, we will find step by step what are the investigation needed and what are the conditions that need specific investigations and what are the result of this investigation. Thank you for watching and Assalamu alaikum wa rahmatullah.